Good morning, students. In this lecture, we will go through healthcare delivery system in Malaysia. These are the learning outcomes. At the end of this session, the student should be able to define system and health system, describe the key functions required in a health system, describe the organizational setup of healthcare system of Malaysia, describe the programs and activities of Malaysia healthcare system. System is a group of interacting or interrelated entities that form a unified whole. A system can be understood as an arrangement of parts and their interconnections that come together for a purpose. It's defined by von Bertalanffy in 1968. Examples of system are legal system, political system, economic system, social, education system, social welfare system, and health system. Example of education system is Ministry of Higher Education Malaysia, health system Ministry of Health Malaysia. Health system or healthcare system is the organization of people, institutions, and resources that deliver healthcare services to meet the health needs of target populations. Health needs objectively determines deficiencies in health that require healthcare, from health promotion activities to palliative care. Health system consists of all organizations, people, and actions whose primary intent is to promote, restore, or maintain health. It consists of all organizations, people, and actions whose primary intention is to promote, restore, or maintain health. Example of person or people: a mother caring for a sick child at home, or a home nurse caring an elderly individual at home, or a nurse caring an elderly person in a old folk home. All these are example of people. Organizations can be private healthcare providers, private hospitals, private clinics, nursing homes. All these are example of organizations. Actions or programs can be behavior change program, environmental health program, vector control activities. Okay. Health insurance organization can be a part of health system. Legislations can be occupational health legislation, occupational safety. Okay. Mental health laws. All these are coming under part of health system. It includes inter-sectoral action of health staff with other sectors. For example, encouraging the Ministry of Education to promote female education. Female education or female literacy is a well-known determinant of better health of a country. So female education, how we can promote female education through Ministry of Education. So it's a inter-sectoral action. Water quality can be improved through Department of Sanitation. So that in turn, through intersectoral action, improves the health system. Key functions required in a health system. These are the key functions. One is oversight on the health needs of the population. Okay, while you are making policies, during policy making or regulation, we have to think about, oversee the health needs of the population. Then second key function is health service provision. So we need to provide health services, clinical services, health promotion services, preventive services, including vaccination, including health checkup, screening programs, all these should be provided. Financing. Government should allot some budget for health system financing. Managing resources like pharmaceuticals, medicines should be made available. Medical equipments should be made available. Personal protective equipments, as in the time of a pandemic, health system need personal protective equipments. Government has to allocate that. They have to find resources for personal protective equipments. Information. Information should be made available. Health personnel should be appointed and they should be competent. Their competency and skills should be developed. How? Through training. That all are components, key functions of health system. One is oversight of health needs of the population, health service provision, financing, and managing resources like medicine, medical equipment, information, and health personnel. Describing the parts, interconnection, and purpose. Okay, health system is defined by Romer in 1991 as the combination of resources, organization, financing, and management. There should be resources should be there, organization should be there, financing and management. There should be combination of all this that culminate in the delivery of health services to the population. Healthcare services. Okay, there are three levels of healthcare provision: primary care service, secondary care service, and tertiary care service. Okay. Ministry of Health of Malaysia. This is an organizational chart. Health Minister is the top authority. Okay, just below that, Deputy Minister of Health. Below that, Secretary General. Okay, Secretary General of Health. Under Secretary General of Health, two Deputy Secretary Generals are there. One is Deputy Secretary General Finance and a Deputy Secretary General Management. And below Secretary General is Director General of Health, DG of Health. Okay, DG of Health is controlling different departments: Deputy Director General Public Health, Deputy Director General Medical, Deputy Director General Research and Technology Development Support, Principal Director Oral Health, Principal Director Pharmaceutical Service, Principal Director Food Safety and Quality, and a Director of State Health Departments. These are under Director General of Health. So, Public Health is there. Deputy Director General of Public Health is there. Deputy Director General of Medical is there. Deputy Director General of Research and Technical Support is there. Then comes Oral Health. That is Principal Director of Oral Health, Principal Director of Pharmaceutical Service, Principal Director of Food Safety and Quality, and a Director of State Health Departments. These are the organizational chart of Ministry of Health. Now, programs and activities of Malaysia healthcare system can be divided into these 6 areas. Public health program is there, medical program, research and technical support program, oral health program, pharmaceutical services, food safety and quality. These are the 6 programs and activities. Now we will go to different subgroups. Divisions under Deputy Director General of Public Health. Okay, Deputy Director General of Public Health has 4 divisions under him or her. Family Health Development Division, Disease Control Division, Health Education Division and Nutrition Division. These are the 4 divisions. Family Health Development, Disease Control, Health Education Division and Nutrition Division. These are the 4 divisions. Next, Deputy Director General Medical. He will be focusing more on the medical services. Okay, medical practice. So these are the 4 components under him. 4 divisions. Okay, Medical Development Division. Okay, Medical Development Division, Medical Practice Division. Okay, Medical Development, Medical Practice. Allied Health Sciences Division. Allied health departments like nursing, pharmacy, paramedics, all comes under Allied Health Division. Then comes Traditional and Complementary Medicine Division. So Medical Development Division, Medical Practice Division, Allied Health Sciences Division, Traditional and Complementary Medicine Division. These are the various divisions under Deputy Director General Medical. Okay. Now, another divisions under the DG of Health, Deputy Director General of Research and Technical Support. What he is doing? Research and technical support. So, he will be focusing on planning. Planning of health services, healthcare provision and healthcare planning. Engineering services. What all engineering services needed? Okay. And next is research. National Institute of Health Secretariat, NIH, National Institute of Health Secretariat is there. So under that, there are so many institutes. National Institute of Health Secretariat is having so many institutes. Institute of Medical Research, that is top medical research institute in Malaysia. Institute of Health Systems Research. Okay, medical research include all the medical systems, like fundamental research and epidemiological research, like that. Institute of Health Systems Research focus on the development of health systems. So it is focusing on health systems research. Institute of Public Health. Institute of Public Health focus on public health programs, public health activities, public health interventions like that. Institute for Health Management. So health management related activities, the development, research and technical support will be done by Institute of Health Management. Then comes Clinical Research Centers. There are so many clinical research centers, CRC. One CRC is in Perak, in Ipoh General Hospital. Like that, all the states have its own CRCs, clinical research centers. It will go through the research done in hospital settings. If you are doing a clinical research or hospital-based research, you have to get approval from Clinical Research Center. And you have to get a NMRR approval, that is National Medical Research Registry approval. That approval is given by Clinical Research Center. And then you they have Institute of Health Behavioral Research. That also is under National Institute of Health Secretariat. historical background of healthcare system in Malaysia. Okay, Malaysia inherited a health system from the British upon independence in 1957. Okay, but with services based mainly in urban areas. Okay, in 1957 Malaysia got independence from British, so the health system they inherited from the health system which was followed by British system. Okay, focusing mainly in urban areas. Healthcare services were expanded as a post-independence priority, particularly for the economically disadvantaged and the rural population. So after independence, Malaysia government focused more on economically backward, disadvantaged and rural population. Okay. From 1956 to 1970, Malaysia followed a three-tier system. Okay. Three-tier system means first there was a main health center for 50,000 population. Okay. One main health center was there for 50,000 population, which was having one doctor and one dentist. Okay. Priority was outpatient care and dental care was given. Then for every 10,000 population, there was a health sub-center was there. Okay. This I am telling for the three-tier system from 1956 to 1970. Three-tier system was there. Health center was there for 50,000 population. Health sub-center was there for 10,000 population, and for every 2,000 population there was a midwife clinics. Okay, so health center was handled by a doctor and a dentist, and outpatient care and dental care was given. Sub-center was handled by medical assistants and staff nurses. Outpatient screening was given and MCH care. What is MCH? Maternal and child health care was given. Then for midwife clinic, 1 in 2000 population. For every 2000 population, one midwife clinic was there, handled by one midwife. Midwife was handling what all services given? Home delivery and home visits for antenatal visits and postnatal visits. Antenatal visits means during the pregnancy period. Midwife used to visit house and see the pregnant women. Postnatal visit, a midwife will visit home and will see the woman during postnatal period after delivery to make sure that woman and child is healthy. Okay. From 1970 onwards, Malaysian primary healthcare system changed to two-tier system. They made it into one health clinic and one community clinic. Health clinic is Clinic Kesihatan, one for 20,000 population. Okay. And a community clinic is Clinic Desa. It is one for 4,000 population. So health clinic or Clinic Kesihatan, these are the staff: doctor, dentist, pharmacist, assistant medical officer, public health nurses, assistant pharmacy officer. These were the staff. Doctor is there, dentist, pharmacist, assistant medical officer, public health nurses, assistant pharmacy officer. What all services given in Clinic Kesihatan? Outpatient services, dental care, MCH care. MCH is maternal and child health care, health promotion and family planning services. Then next tier is two-tier system now. Next tier is community clinic or Clinic Desa, one for 4,000 population. Two type of staffs were there. One is community nurse and one midwife. Okay. For 4,000 population, one community nurse and one midwife. What all services given? Maternal and child health care, home care, and family planning. Maternal and child health, home care, and family planning services. No home delivery is there. Now they are promoting hospitalized delivery. So they are referring them to nearby hospital where gynecologist is there. This source is Family Health Development Division, Ministry of Health. So Public Health Administration in Malaysia. Okay. Public health, public sector health services in Malaysia are centrally administered by Ministry of Health through its central, state and district office. Central health office is there, state health office is there, and a district health office is there. And some services through other departments also. So number of healthcare facilities over the years. Okay. So in 1957 there were no community clinics were there. From health clinics were there, 7 health clinics were there. Okay. And in slowly it increased. In 2008, 1927, 1927 community clinics are there. And 897 health clinics. Health clinics means clinic Kesihatan are there. Community clinic, clinic Desa are there. 1927. Total 2824 clinics are there. Primary healthcare facilities. Okay. Number of Ministry of Health hospitals. Okay. Number of hospitals. District hospital was 56 in 1960 and in 2009 it became 75 district hospitals. Large hospitals with specialists. Specialist care hospitals. In 1960 only 10 hospitals were there, but in 2009 it became 55 hospitals. So total of 130 hospitals are there. Ministry of Health hospitals are there in 2009. Okay. Ministry of Health, primary healthcare facilities. Okay. At independence in 1957, there were 10 major hospitals and 56 district hospitals, plus 7 institutions for leprosy and mental health patients. Okay. In 1957, 10 major hospitals and 56 district hospitals were there, plus 7 institutions for leprosy and mental health patients. From 1960 to 2009, the number of Ministry of Health hospitals nearly doubled. Private hospital also increased from only a few in 1950s to 209 private hospitals. Okay, 130 Ministry of Health hospitals are there, 209 private hospitals are there. Nevertheless, these provided less than 1/4 of the country's hospital beds. Majority of the hospital beds are under Ministry of Health hospitals. Less than 1/4, less than 25% of hospital beds are provided by private hospitals. Health services to specific population by other departments. Okay. There is inter-sectoral coordination in Malaysia. So other departments also provide healthcare facilities and health services. Okay. Ministry of Higher Education runs university teaching hospitals. So university teaching hospitals are under Ministry of Higher Education. Ministry of Defense has several military hospitals and medical centers. So military hospitals and medical centers are under Ministry of Defense. There is one Aboriginal Affairs Department. That is Orang Asli Affairs Department. So that department provides health service to the indigenous population in collaboration with the Ministry of Health. So these are the three main inter-sectoral coordination in Malaysia. Ministry of Higher Education runs university teaching hospitals. Ministry of Defense has military hospitals and medical centers. And the Department of Aboriginal Affairs or Orang Asli Affairs provides health services to the indigenous population in collaboration with the Ministry of Health. Okay. Then some more departments. Department of Social Welfare provides nursing homes for the elderly. So nursing homes for the elderly is provided by is controlled by Department of Social Welfare. Ministry of Home Affairs. Okay, Ministry of Home Affairs manages drug rehabilitation centers. Okay, Ministry of Home Affairs deals with drug abuse rehabilitation centers. Ministry of Housing and Local Government provides environmental health services. Okay, Ministry of Housing and Local Government. Okay, and limited health services. Okay, Ministry of Housing and Local Government provide limited health services also, as in Kuala Lumpur Federal Territory. Sometimes vector control activities are done by Ministry of Local Government. MBI, that is Majlis Bandaraya Ipoh, is doing vector control activities. That also under environmental health services. Okay. So now public health administration in Malaysia given by non-governmental agencies. Now we told about the governmental departments through inter-sectoral coordination, right? Non-governmental agencies. There are so many non-governmental agencies like Red Crescent Society and St. John's Ambulance. They provide emergency ambulatory and relief services. Red Crescent Society and St. John's Ambulance provide emergency ambulatory and relief services. Lions Club provides rehabilitative services for those who are disabled. They give rehabilitation services, training, job rehabilitation, social rehabilitation, and physical rehabilitation. All these are given by Lions Club. Family Planning Association provides reproductive and health services. Okay, Family Planning Association is there. Then some other non-governmental organization caters to people with special needs. What are the people with special needs? Like Down syndrome, those with cancer, those with autism, those with thalassemia, intellectual disabilities, all these. Okay. They provide cancer and hospice care. Hospice care means care for terminally ill patients. Okay. Hospice care and run community-based psychosocial and rehabilitation centers as well as halfway homes. Okay. One in Ipoh there is one dementia care center. It is run by Dementia Society. And there are so many services provided by Parkinson's Society. Parkinson's Society. Okay, they are giving care to people affected by Parkinsonism. Okay, private health sector provides mainly curative and diagnostic health services in urban areas. They focus mainly in urban areas. Okay, private health sector. Most primary care in urban areas is currently provided by private practitioners and GP, okay, general practitioners or family medicine specialists. And there are large number of private dental clinics and retail pharmacies as well as growing number of private hospitals in urban areas. Okay, now we will go through the public health administration in Malaysia, private health sector. Number of doctors in public and private hospitals in Malaysia. Okay, in 1987, public doctors in public sector was 2,463 and the private sector was 3,331. So ratio of medical doctors to population was 1 is to 2,852 population. For every 2,852 population, one doctor was there in 1987. But in 2010, number of doctors increased. Now the doctor population ratio in 2010 is 1 is to 905. For every 905 population, one doctor is there. And the number of doctors in public is higher. It is 22,429 doctors work in public sector compared to 10,550 doctors working in private sector in 2010 statistics. So it shows that the number of doctors increased. Okay, number of doctors working in public sector increased so that more doctors are able to give services to rural and disadvantaged population. And the number of doctors to population also increased. 1 is to 905. That also a good. Okay. Public health administration in private sector. Experienced specialists were disproportionately concentrated in the private sector where their skills may be underutilized because of limited patient pool who were occasionally presented with minor conditions not requiring the attention of specialist expertise. That was one study done in 1996. It showed that experienced specialists were disproportionately concentrated in private sector. They were not able to give their expertise to the public because people going to public were needing less services. So they were not utilized. So experienced specialists were not fully utilized. Specialists in the private sector made up 55% of the total national specialist pool, but only served 25% of major cases. That also shows major cases or major diseases, patients with major diseases always consulted public sector. So when specialists are working in private sector, they were not able to give their full expertise to the people who are in need. By the end of 2020, there were approximately 33,000 doctors in Malaysia and for a population of 28.35 million. Doctor population ratio was 1 is to 850. Okay, around in 2010. Number of doctors increased. Okay, from 46,491 doctors in 2015 to 50,087 doctors in 2016. And the ratio of doctor to population changed from 1 in 671 population in 2015 to 1 in 632 people in 2016. So that's a good change. Number of doctors is increasing exponentially and the trend suggests that we shall have about 65,000 doctors by 2020. By 2020, Malaysia will have a population of about 32 million and the doctor population ratio will be slightly under 1 is to 500, which is well below WHO recommendation of 1 is to 600. WHO has given Malaysia's ideal doctor population ratio is 1 is to 600. But by 2020, it is projected to have 1 is to 500. So that's better than the WHO recommendation. So need for improvement in specialist care. Okay. So 2005, number of posts were 3,310 was the number of specialist post in public hospitals. Okay, so number of posts filled was only 1,321. That means that only 39.91 percentage of required posts are filled by specialists. Okay, in 2005, please look on the 2005 figure. 2005, 3,310 posts are there for specialists in public hospital, but only 1,321 posts were filled. That means only 39.91 percentage of the posts are filled by specialists. So need for improvement in specialist care. More specialists need to be appointed in public hospitals. Healthcare planning in Malaysia. What is a healthcare planning? Malaysia is an upper middle income country with a health system and health status commensurate with its level of development. So Malaysia's health system and health status is part to the development. Okay. 11th Malaysia plan. There is an 11th Malaysia plan for from 2016 to 2020. It articulates the development goals of Malaysia over 5 years period. And health is the key component of the plan's major thrust area. Okay, so what was the logo? Improving well-being for all. That's the logo for health under 11th Malaysia Plan 2016 to 2020. Improving well-being. Okay, now we will see what are the focus areas of 11th Malaysia Plan. What are the focus areas? Okay, achieving universal access to quality healthcare. That's the main focus area. Achieving universal access to quality healthcare. How it is done? Enhancing targeted support, particularly for underserved community, like Orang Asli community. They are underserved. So targeted support is enhanced targeted support for underserved communities. Then improving system delivery for better health outcome. So improving the delivery of services for better health outcome. Expanding capacity to increase accessibility. Okay, more capacity like more mobile clinics, more mobile healthcare provision, more community health center, more skilled staff. Understood that can increase accessibility of service. Intensifying collaboration with private sector and NGOs to increase health awareness. So it is known as public-private participation. So collaboration with the private sector and NGO. NGO is non-governmental organization to increase health awareness. Okay, these are the summary of Malaysian health system delivery. Okay, Malaysian health system delivers a comprehensive range of services through public and private providers. There are so many public providers are there and private providers are there. Public sector provides 76.7% of inpatient services. Okay, that's a great thing. 76.7% of inpatient services are provided by public sector with an average stay of 6.2 days compared to 5 days in private sector. So public sector is providing average stay of 6.2 days. So more people requiring prolonged hospital stay, they prefer public sector. Maybe because of affordability also. Private sector may not be affordable to them unless they have a health insurance. Median stay in public sector is 3 days compared to 5 days in private sector. Average stay of 5 days in private sector with a median stay of 4 days in private sector. Urban population uses significantly more private inpatient services than the rural population. So urban population uses more private inpatient services. 28.8% of urban population uses private inpatient services compared to 6.3% among um, rural population. Urban population uses more private inpatient services than rural population. Maybe because of affordability. Community perception of health services are high. 77.8% of respondents rated government clinics as good or excellent compared to 70.9% for private clinics. So, community perception of health services given by public or government clinics is good or excellent. 77.8% of respondents rated government clinics as good or excellent compared to 70.9% of respondents rated private clinic as good or excellent. Main points of dissatisfaction with government clinics are perception of long waiting times, and another one is not able to choose the doctor. So that is the two things, long waiting times and not being able to choose the doctor. These are the 2 points of dissatisfaction with government clinics. For private care, high cost was the main concern and lack of affordability. People were not able to afford the high cost in private care. However, there are still some pockets of vulnerable and disadvantaged groups that face challenges accessing health services, like those living in remote areas, those living in remote villages or unreachable villages. They are still depending on mobile clinics, mobile health team to reach there and cater services to them. So that's one area of concern. Thank you.